Welcome, everyone, and thank you for joining us for the third virtual UMiami Health Talks. Tonight's title is Female Pelvic Floor Disorders, What to Know About Urinary Incontinence and Vaginal Prolapse. Tonight's UMiami Health Talk is presented by UHealth Virtual Clinics. UHealth's expert providers are ready to care for you either in our facilities or wherever you are virtually. We invite you to learn more about the measures we have in place to keep you safe, as well as all your appointment scheduling options. Visit uhealthvirtualclinics.org so you can see everything we've done to keep you safe. Tonight, we're going to hear from UHealth physician expert, Dr. Katherine Amin. Dr. Amin will present on female pelvic floor disorders, what to know about urinary incontinence and vaginal prolapse. She will define the types of urinary incontinence, evaluation, and the new treatment options that we offer at UHealth. During the presentation, by the way, we're going to poll you in the audience on questions relevant to the discussion. Your answers are going to be anonymous, but we really encourage you to participate and give us your feedback. It's an important addition to the conversation. Also, there is going to be a Q&A session that takes place at the end of Dr. Amin's presentation, and it's going to answer a lot of the questions that you might already have ready to ask. Some have been submitted in advance, but don't worry, there's plenty of time for you to do so. Look at the bottom of your Zoom screen where it has the Q&A icon, and that is where you can ask the panel questions, and it's going to, again, remain anonymous, but you have an opportunity to do that throughout this hour, and we are going to field those questions and prepare them for our speaker. So I am pleased right now to introduce our presenter, Dr. Katherine Amin. She is board-eligible urologist at UHealth. She completed her fellowship training at Virginia Mason Medical Center in the area of female pelvic medicine and reconstructive surgery. She completed her residency at Mount Sinai Medical Center in New York. Dr. Amin's clinical specialties include female pelvic floor reconstruction, pelvic organ prolapse, urinary incontinence, minimally invasive surgery, robotic surgery, neurology, fecal incontinence, transvaginal mesh complications, obstetric fistula, female sexual health, lower urinary tract disease, and male voiding dysfunction. A broad section we have available for you tonight with very interesting discussions. By the way, Dr. Amin works out of UHealth Plantation in Broward, the Professional Arts Center in downtown Miami, and the Lennar Foundation Medical Center in Coral Gables, and that is only one of the spectrum of all the UHealth locations that we have in South Florida, from Dade, South Dade to Broward. So please join me right now in welcoming Dr. Amin to discuss our topic again, female pelvic floor disorders, what to know about urinary incontinence and vaginal prolapse. Welcome, Dr. Amin.
Thank you, Eliana, and thank you for that wonderful introduction. And thank you to everyone that is here tonight. And I'm so excited to be invited into your homes to talk about this very important topic that's near and dear to my heart. So I first wanted to start out with a little background. So specialization in the field where urology and gynecology meet has been around for many years. Urologists call it female urology, and gynecologists call it urogynecology. Then in 2011, the two specialties came together and created a subspecialty, which they named female pelvic medicine and reconstructive surgery. Here at the University of Miami, we have specialists from both backgrounds, and I happen to be a urologist who specializes in FPMRS, which is very similar to urogynecology. They're essentially one and the same. Tonight, we will be discussing female pelvic floor disorders. We will be focusing on the bladder as we discuss urinary incontinence, and then focusing on the vagina and the uterus as we discuss vaginal prolapse.
Well, I suppose that we have jumped to the first poll question, Dr. Amin, and that is on your screen right now. Here's the question to all of you in the audience to help us understand. When was your most recent visit to the gynecologist or urogynecologist? Here are your choices on the screen. Your last visit, less than 1 year ago, 1 to 3 years ago, more than 3 years ago, never. Your choices are on the screen of when was your most recent visit to the gynecologist or urogynecologist. We wait for people to answer. These are the types of poll questions we're going to have. So there you go. 52%, Dr. Amin, say less than a year ago. 1 to 3 years ago, 35% of the audience answered, and more than 3 years ago, 9% answered, and 3% answered never.
Okay, so I'm glad we have this is very relevant for the audience that we have. So that's good to hear. So I will be first talking about urinary incontinence, and I want to address what is a healthy bladder. So urine is made in the kidneys, which are located in the upper back behind our ribs, and then they travel down to the bladder and the pelvis via tubes called ureters. The bladder is a muscular sac located behind the pubic bone. And the bladder muscle stretches to store urine. So it should be holding urine 90% of the time, and urine should be controlled and infrequent. Pelvic floor muscles help hold the urine in the bladder during certain events like coughing and sneezing. When we have increased abdominal pressure, the pelvic floor muscles should keep urine inside. During urination, when we tell the bladder, when the brain tells the bladder to go ahead and urinate in a controlled fashion, the bladder muscle should squeeze. The sphincters and valves open to allow urine to flow out, and the bladder should empty completely. The bladder, when it's empty, is about the size of a small pear behind the pelvic bone. However, problems can arise with how the bladder functions, and today we'll be discussing issues with storage, including overactive bladder, urinary urge incontinence, stress urinary incontinence, and mixed urinary incontinence. Overactive bladder or urgency is a combination of symptoms, including urinary urgency, where you have to run to the bathroom, and that is sometimes accompanied by leakage, unwanted leakage of urine, increased daytime frequency. So oftentimes I hear patients say that they have to urinate sometimes up to every hour or multiple times an hour, and often have to get up at night more often to urinate as well.
So that leads us to the next poll question. Have you ever experienced unwanted urinary leakage that disrupted your daily life? It's a yes or no question. Have you ever experienced unwanted urinary leakage that disrupted your daily life? And as a reminder, we invite you to send your questions to our speaker using the Q&A feature at the bottom of your Zoom screen. It's the little icon box that says Q&A with those little thought bubbles, so that we can answer as many questions as possible during this hour. Meantime, here's our poll question. So 70% of the audience says that yes, they have experienced unwanted urinary leakage that disrupted daily life, 30% no.
So and that leads me to the next point, where unfortunately overactive bladder is quite common. It affects up to 17% of the US population. 1 in 6 adults are affected, and it is predisposed to older women, or women as we get older, they're more affected. So the other type of leakage that I'll be addressing is stress urinary incontinence. And this is symptoms of accidental loss of urination during increased abdominal pressure. Examples of these events include sneezing, coughing, lifting heavy objects, or physical exertion, such as going to Zumba class, yoga, and doing physical activities. This is usually caused by a weakening of the muscles that help hold the urine in during storage. Again, the pelvic floor muscles. Stress urinary incontinence is very common among women. It can affect up to half of women, and many women wear multiple pads per day, unfortunately, and these symptoms can be quite bothersome. The next type of urinary incontinence is mixed. This is when a combination of both urinary urgency and stress urinary incontinence occur. And this is also can be quite common. Up to 30% of women that describe incontinence have mixed incontinence. And it can be quite devastating as well, leading to depression, affecting employment, social interactions, and emotional well-being, where many women say that they feel like they have to hide at home, and they are embarrassed to go outside. So in terms of what to expect if you were to seek medical advice or professional advice for these disorders. So I'll be talking about the questions you may be asked by your physician, the pelvic exam that they should perform, and common tests that we may recommend. So in terms of questions you may be asked, we would ask for you to describe your current symptoms. So we want to know, how is the urgency that you're feeling? When do you feel that urge? How bothered are you by that? And how many pads do you have to wear during the day? How often are you going to the bathroom during the day? Or what about at night? How often do you get up at bed? Do you ever wet the bed? And do you feel like your stream has weakened? We'll get into prolapse later, but we ask about questions about a vaginal bulge. And again, because the pelvic floor is such a tight space, and there are three major organs there, including the rectum, we also ask about bowel function. And we also want to know the balance between what you put into your body in terms of fluid intake and what is produced by the through the bladder as well. And you may be also asked in particular about your obstetric history, which we'll again talk about later, but how many births you've had, or how many children you've had, and the delivery of that as well. And when you go to your provider's office, a pelvic exam is usually performed. We want to know so many things and that are relative to the pelvic floor, and that include the quality of vaginal tissue, and the measurements that we perform are to assess if there is prolapse, or if there is any descent of the organs through the vagina, and the strength of your pelvic floor muscles. And then we ask you to do things like cough, and to assess if you do have leakage, and to see if everything looks normal within the vagina. Other things that we would do normally would be to obtain a urine sample to ensure that you do not have an infection, and sometimes blood work. Additional testing would be to make sure that you're emptying your bladder all the way, and again, to assess avoiding diarrhea is to assess how much you're drinking during the day versus how much you're urinating out. And we will also discuss in detail about the urodynamic test that we often order, and a cystoscopy. Occasionally we order imaging like an ultrasound, and rarely we order a CT scan or an MRI. Cystoscopy is a procedure to look at the lining of the bladder. In the middle, this is a picture of a normal bladder that shows the normal blood vessels. And on the right, this is a picture of a bladder that's quite stretched out. Looks like the muscle has had to squeeze vigorously against very tight pelvic floor muscles, or prolapse. So in terms of urodynamics, we order this very often. This is because it gives us so much information. These are bladder function tests. It tells us how well your bladder fills and empties, and then we are able to examine what the bladder is doing during leakage episodes. First, we ask you to come with a full bladder, and we have you urinate and into a special toilet that will measure how fast or slow your urinary stream is. And then we do an ultrasound of your lower belly to assess how your bladder emptied. Then we do the cystometrics component. This is a test that we are able to assess how the bladder is storing urine and the bladder pressure. We put a small catheter into the bladder and measure the pressures. And we are able to know exactly when you have those urgency episodes. And it's an interactive test. So we ask you questions like, if you're driving on the highway and when do you feel the urge where you have to look for an exit sign? Or if you're driving on the highway, and when do you feel a strong urge where you feel like you have to pull over to the side of the road? And so again, it's an interactive test where we want to know what your symptoms are compared to what your bladder is doing. And we do ask you to urinate, and we are able to measure the strength of your bladder. So once we have learned all about you during these exams and getting your information, then we can focus on which treatment options would be best to improve your symptoms and quality of life. So first I'll be talking about stress urinary incontinence for treatment options. First and foremost, it's important to always think about how we can reduce our risk factors for stress incontinence or leakage when we cough and sneeze. And that's important for weight loss and smoking cessation. Next, things that can be non-surgical or less invasive would be pelvic floor muscle training, pelvic floor physical therapy, and an incontinence pessary. Pelvic floor muscle training is meant to have a professional actually to help you strengthen your pelvic floor muscles. We have physical therapists here at the University of Miami, and they help you control the urge and to reduce or help stop urine leakage. It is important to practice on your own. Normal regimens to see a physical therapist usually include visits once a week for 12 weeks. An example of something that you can buy over the counter to help with stress incontinence is the Poise Impressa. It is similar to a tampon, but safe to use for short periods of time. It helps compress the urethra to prevent leakage with coughing, sneezing, and lifting. An incontinence pessary is a silicone ring that is placed in the vagina and compresses the urethra against the posterior aspect or the back of the pubic bone to prevent leakage when you cough or sneeze. And this is something that we fit for your pelvis and your anatomy, and we teach you how you can take it out and put it in independently. So oftentimes non-surgical options just aren't enough, or the severity of your symptoms are quite high and patients seek more definitive treatment through surgery. I will be highlighting the most common surgical procedures that we usually perform at UHealth. However, there are many options besides what is presented here today. It is also important to speak to your doctor about which is the best treatment for you and to give you a full explanation of the risks and benefits. First, I'll be talking about urethral bulking and also addressing the mid-urethral sling. So urethral bulking agent is a filler material that is injected into the urethra at the location of the pelvic floor muscles to increase the resistance of the bladder outlet and prevent leakage. The advantages are that there are minimal side effects and it's a quick recovery, meaning that there are little to no limitations after the procedure. So you can go ahead and lift heavy objects, go back to work the next day. But this does have the lowest success rate. I would say it's about 40 to 70% for success rate. And oftentimes women do seek to have more bulking agent injected, to maybe 1 to 2 years later on. The mid-urethral sling is something that supports the pelvic floor muscles and helps the urethra resist increases in abdominal pressure that are transmitted to the bladder. There are 2 types of mid-urethral slings that are often placed. First is the retropubic sling. And this is a sling that goes behind the pubic bone so that you have 2 small incisions in the lower abdomen and 1 small incision in the vagina. The next is a transobturator sling, which courses through each side of the pelvic bone, and you have a small incision on the inner thigh and a small incision in the vagina. The newest type of sling is the mini sling that only spans within the vagina. The advantages include a high success rate, about 80 to 85%. It is a same-day surgery, so you do go home that same day. And disadvantages is that it is a mesh implant. Advantages is that it's permanent, but we will talk more about the complications that can be associated. They are uncommon and rare, but can happen. And their disadvantages include the risk of causing or exacerbating urgency or frequency. An autologous fascial sling is very similar to the mid-urethral sling. However, no mesh is used. A piece of strong connective tissue called fascia is obtained just above the muscle layer. Fascia can come from either an area in the lower belly, and this incision is similar to a C-section scar, or fascia can come from a strong ligament along the outer thigh. And there is a high success rate with this type of procedure, and there is, of course, no permanent mesh that is involved, and we use your own natural tissues. However, this procedure can be more painful because we are making more incisions and larger incisions than the synthetic sling, and it carries this, a similar risk, small, but can be there, with urinary urgency and frequency. Next, I'll be talking about the overactive bladder and our treatment options for this. And again, this is when the bladder squeezes when it should be in resting. So this can happen. The bladder could be irritated, and there are certain foods, again, thinking about what we put into our body can affect our body. So irritants that can bother the lining of the bladder include caffeine, carbonated beverages, spicy foods, or foods with a lot of acid, such as lemons or limes. We also recommend weight loss and fluid management, including trying to limit fluids before bedtime, pelvic floor muscle exercises, and bladder training to, again, suppress the urge. And if those aren't enough, then we move on to what we call second-line therapy, and that includes medications. First, we often try vaginal estrogen, particularly in women that are postmenopausal, meaning that these women have less estrogen in their bodies because the ovaries stop making estrogen after menopause, and the vaginal tissue is very sensitive to that. So the tissue becomes very thin, and the bladder, again, is close to that vaginal tissue and gets irritated and causes the urgency and frequency. So vaginal estrogen is an option to help improve that. Other medications that help relax the bladder muscle itself are anticholinergic medication and beta-3 agonist medication. Anticholinergic medications have been around for a very long time. This is an example of a list of the medications that are available right now over on the right that you may have heard of. And the goal of these medications is to decrease the urge and leakage episodes that you experience during the day. And many of these medications have similar efficacy. So, but the side effects can range differently among the different types of medications because some of them target the bladder differently. And common side effects for anticholinergic medications include dry mouth and constipation, which can be quite frustrating for patients. The newer type of medication is called a beta-3 agonist medication. And again, the purpose of this medication is to relax the bladder so that it holds and stores urine better, and to improve your quality of life. Common side effects, again, because this does relax the bladder and targets the bladder in a different way. So it's targeting different receptors, so it has different set of side effects. And they can include an increase in blood pressure or headache. And moving on, if medication is not enough, sometimes we often do urodynamics to get more information about your bladder after we try the medications and you're still having symptoms. And then we can move on to more definitive options and what we call third-line options. And this is the surgical or procedural type of options. And this includes peripheral tibial nerve stimulation, injection of botulinum toxin or Botox, and sacral neuromodulation. So first we'll talk about peripheral tibial nerve stimulation, or PTNS. And the background of this is that we are targeting the nerves that innervate the bladder. So we want to target the communication between the brain and the bladder. And we can actually do this at the level of the spinal cord, along the sacrum, or along the inner ankle. PTNS was first used in patients in 1983. So this has been around for a long period of time. This is a procedure that is done in the office where a small acupuncture needle is placed at the inner ankle, and you are connected to a machine that stimulates the nerve for a short period of time. It is done once a week for 12 weeks. So disadvantages could be that it does require significant time commitment. And among the three options that we'll be talking about, it does have the lowest effectiveness, but it has the least amount of side effects because it really just involves an acupuncture needle that is stimulated for half an hour. And also it only lasts usually about 4 to 6 months, and you have to continue to do it in order to see the benefits. Next, we'll be talking about Botox. Botox is a chemical that paralyzes the muscles where it is locally injected. It is used in other parts of our bodies, like the face. And again, the purpose is to paralyze the muscles and relax the bladder. So advantages is that it's quite effective, and disadvantages is that it usually wears off in about 3 to 6 months. So multiple injections have to occur. I usually say twice a year injections. And there is a small risk of relaxing the bladder too much. So some women do require a Foley catheter. Again, the literature reports about 6%. I've noticed in practice it's a little bit lower than that. And then there is also a small risk of a bladder infection after the procedure. Sacral nerve modulation is another option. This is a pacemaker that targets the nerves along the spine that innervate the bladder. It is indicated for overactive bladder or urge incontinence, fecal incontinence, and urinary retention. Again, because it is targeting the nerves that communicate between the brain and the pelvic organs. So it is indicated for all three of these conditions. So advantages include that it's quite successful, even at up to 5 years in the literature that we have reports of. And there is no risk of retention. The battery life for this pacemaker can last 5 to 10 years. And historically, it has not always been MRI compatible for full body MRIs. However, this has changed even as of this year. So now that there are new leads and new parts to the pacemaker so that it is safe for both head and body MRIs. So we're very excited about that. And disadvantage is that it is an implant. It usually involves a staged period, meaning that we usually do a trial period to make sure that it works for you and that you see improvement before we place the whole battery in the implant in. So we just want to do that trial period to prove that it works for you as a pacemaker.
So as we get ready to ask the third poll question tonight, have you ever found it difficult or embarrassing to bring up leakage issues with a primary care provider? All of you listening and watching tonight, please answer yes or no if you've ever found it difficult or embarrassing to bring up leakage issues with a primary care provider. And I want to welcome so many of you who've jumped on our call tonight. This is UMiami Health Talk, Female Pelvic Floor Disorders, What to Know About Urinary Incontinence and Vaginal Prolapse. These virtual health talks help our patients participate in topics of great interest. And there is the response. 26% said no, they did not find it difficult or embarrassing, and rather yes, 26% said yes, and no, 74%.
That's great to hear. That's good to hear that you feel comfortable talking to providers, and hopefully they're asking the right questions too, and we're asking the right questions. So the second part that I want to address tonight is what to know about vaginal prolapse. So in general, it's important to define, what is a healthy vagina? And the vagina is part of the pelvis that is made up of bony structures, strong ligaments and muscles that house 3 major organs: the bladder, the rectum, and the uterus. This is an example of how the bones of the pelvis create a bowl to house the organs, and the muscles in the connective tissue suspend the organs inside and keep everything elevated inside. Every vagina has 3 compartments. The front, or the bladder, is the first compartment. So this is the front of the bladder. And the back makes up the wall where the rectum is located. The top of the vagina is where the uterus or the vaginal ending, if you've had a hysterectomy, is located. Therefore, when prolapse occurs, it can happen in each compartment or all 3 compartments. So anterior prolapse is when the bladder herniates through the vaginal wall. So the front of the vagina is herniating through the wall, through the vagina, or herniating downwards. Posterior prolapse is when the rectum is herniating through the vaginal wall downwards and through the opening of the vagina. And apical prolapse, when the uterus is still in place, occurs when the uterus is herniating downwards. And apical prolapse after hysterectomy occurs when the top of the vagina, which we call the vaginal cuff, or the apex, is herniating downwards through the vagina and towards the vaginal opening. So many things can cause vaginal prolapse. First of all, genetics can play a component, and this has to do with the quality of your connective tissue and how stretchy it can be as we get older. And family history also does play a role. More importantly, the number of childbirths and the type of delivery also play a large role in vaginal prolapse. And again, the more amount of trauma that our pelvic floor endures through childbirth because of the increased pressure can cause prolapse. Previous hysterectomy, or if your uterus has been removed, can be a risk factor. And other things like cough or being overweight can also cause increased abdominal pressure and cause prolapse. So vaginal prolapse is quite common, and it does increase with age, again, as our tissues become more relaxed and stretch as we get older. So prolapse is even present in about half of women by the age of 70, and we expect it to continue to increase as the population grows older by 2050. So I have a lot of patients ask me what the symptoms of vaginal prolapse. How do I know when I have vaginal prolapse? So some women don't have any symptoms at all. Other types of symptoms can include if you feel a pelvic pressure or a little heaviness in the vagina, if you feel a sensation of a bulge in the vagina, like a ball coming down, and if you feel as though you have to push the bulge back into the vagina when you urinate or have a bowel movement. Constipation can be also another symptom, difficulty evacuating stool. Pain with intercourse can also be a symptom. And difficulty emptying the bladder or slow urinary stream can also be a sign of prolapse. So the questions that we ask are for prolapse are similar, again, and we're going to ask about your urinary symptoms and your bowel symptoms as well, because these organs are so tightly knit within the pelvis. We again perform a pelvic exam, very important to take the measurements and note the severity or grade of prolapse. And we also perform imaging tests, particularly for a pelvic ultrasound to assess the size of the uterus or thickness of the uterus lining if your uterus is still in place. So in terms of treatment, I'm going to be discussing non-surgical and surgical options. So if you don't have symptoms from prolapse, you can of course observe. Even if you do have symptoms, you can still observe most of the time if the severity is not quite high. And other options for non-surgical include pelvic floor physical therapy, again to make those ligaments and muscles stronger, and pessary. So a pessary is a space-occupying device in this case, and it is placed in the vagina to support the pelvic organs. There are different shapes and sizes used for different types of prolapse, and if you choose to have a pessary, you undergo a pessary fitting to choose which shape and size is right for you. You can remove the pessary on your own or have a medical professional remove the pessary every 1 to 2 months to clean and reinsert. It should also be taken out prior to intercourse. This is an example of a pessary in place and how it really truly is meant to sit behind the pelvic bone and support the organs. In terms of surgical options, there are reconstructive or obliterative options. So reconstructive options are to restore anatomy to a healthy vagina, where all the organs are deep inside the vagina and well supported and well suspended. Obliterative surgical options are to close off the vagina and create a wall so that organs cannot bulge downward any longer.
So we have the next poll question. Have you or anyone you know considered surgical interventions to address prolapse? Yes or no? And in the meantime, I want to assure all of you that yes, this talk is being recorded because I know you're asking that question. And it's so comprehensive and such a broad spectrum of topics that Dr. Amin is covering that you will have access to the video afterwards so that you can see and hear this presentation again. So in the meantime, please help us answer, have you or anyone you know considered surgical interventions to address prolapse? Yes or no? 41% say yes, 59% no.
Okay, it's about half and half. Very interesting. So, and I'm sure many of you actually have undergone surgical repair as well. So in terms of, again, for reconstructive options, there are many type of options and operations that we offer. I will only be talking about a few. There are many different ways to reconstruct the pelvic floor. So they all use the same surgical principles, and our goal is always to achieve your goals. So improve your quality of life and to minimize your symptoms. So we can also combine the procedures, and again, it's not usually just one compartment that is prolapsing. It's often multiple compartments that are affected. So we have to combine a lot of these procedures. So I will be discussing how we can address the anterior front of the vagina, and this is with a bladder repair or cystocele repair, and how we can offer support to the back of the vagina through a rectocele repair, again, targeting the rectum and the wall of the rectum. And then we'll be talking about apical repair, or the top of the vagina, and this is with or without the removal of the uterus. So a cystocele repair is the repair of when the bladder is herniating through the vagina, and this, the purpose of this is to create support along the weakened fascia, and we use absorbable stitches to do this. The success rate is about 60 to 90%. And for rectocele, again, we use stitches that absorb and melt away over time. And the purpose is to give added support and strengthen the fascia that has become weakened where that wall is herniating. And we may, at the time, place deep stitches at the opening of the vagina at the back for added pressure, or for added support, I'm sorry. And the success rate is about 75 to 90% for this. So in terms of when we want to address the top of the vagina, and we often think about when the uterus is still in place, when it is appropriate to perform a hysterectomy at the time of the prolapse repair. We do this because it does enable access for safe and durable apical repair options. And we want to perform a more durable repair to internally suspend the top of the vagina. So the top of the vagina, we're fighting against gravity in a lot of these cases. So we are trying to push everything back up from below, or pull everything back up from above, and in making sure that everything again is deep in the pelvis. So the hysterectomy can be performed through the vagina or through the abdomen, and sometimes we remove the fallopian tubes or the ovaries. When we perform an apical repair through the vagina, this is a vaginal suspension, and we're performing it through the vagina, meaning it's a vaginal surgery, so there are no incisions in the abdomen, just through the vagina. And we can do a hysterectomy at the same time if the uterus is still in place. And what our goal is to stitch the vaginal walls to a deep ligament in the pelvis, and no mesh is used for this surgery. The success rate is 65 to 83% for this. And we can also perform an apical repair through the abdomen. We call this a sacral colpopexy. It's a long word, I know, but it is a surgery that is performed through the abdomen, and we often do it robotically or laparoscopically, meaning that there are small incisions and small instruments that are used. And we do use permanent graft material to suspend the vagina to a normal position. And the permanent graft material is attached to a strong ligament along the sacrum. The success rate for this is quite high, 80 to 90%, and lasts quite a long period of time, again, because of that graft material that is used. For obliterative vaginal surgery option, a colpoclaesis can be performed. This is when the internal vaginal canal is closed off to correct the prolapse and to prevent organs from bulging through the vagina. And after the surgery, the outside looks the same. However, the vagina is shortened and narrowed, and vaginal intercourse is not possible afterwards. So usually women are often widowed or not interested in intercourse, and they are often older that choose to go through, undergo this surgery. But the success rate is quite high. When we are treating prolapse for surgery in particular, we are trying to hit the sweet spot with all 4 of these components, and that is to relieve your symptoms, restore your anatomy, and to improve your quality of life with minimal risks. So I just wanted to touch briefly on what mesh is and what types of mesh are safe. Mesh is a porous graft material that is permanent and thought to be integrated into your own tissue to help create more support, given that your tissues have already become weakened naturally and over the natural course of the pelvic floor disorder. So that's why mesh is introduced. So mesh is safe for the mid-urethral sling, which offers support underneath the urethra. Mesh is also safe when we place it in through the abdomen with a sacral colpopexy, and we cover the mesh with your own tissues. So we cover it with your own tissue, and the mesh is not exposed to any of the organs in the abdomen. And as you know, you may have heard that the FDA has banned the sale of larger sheets of mesh that are placed through the vagina for prolapse repair. Again, this is, we no longer use mesh through the vagina when we're doing vaginal surgery for prolapse, because the vaginal skin is quite thin, and when we use those larger sheets of mesh, there are more risk of side effects. So in terms of what we're doing, what kind of research we're doing at UHealth, I am very passionate about improving patient understanding of the pelvic floor disorders. We are also looking at racial disparities and socioeconomic disparities in pelvic floor disorders and outcomes. And we are also looking at the urinary biome affecting bladder infections and urinary incontinence. So what qualities of your urine can affect your urinary symptoms.
Okay, so time for the final poll question. This will be the end of the poll before we get to the Q&A with this very comprehensive discussion you've been hearing. The last survey question is, have you been nervous about seeing a provider for urinary incontinence or prolapse during the COVID-19 pandemic? Very much top of the mind for all of us, and certainly in patient care and going to hospitals and clinics right now. So have you been nervous about seeing a provider for urinary incontinence or prolapse during this COVID-19 pandemic? Yes or no?
Okay.
Oh, that's another 50-50, Dr. Amin. So 50%.
Okay, yes.
No.
I think this is so relevant and so important to bring up today because, you know, this is our daily lives now and this is what we're living with. So I do want to reassure you that here at UHealth, we are doing everything that we can to make our patients safe. And there are several different components to that. We are giving all visitors and UHealth employees are wearing masks. So when you enter the door, you're actually given a new mask to wear during your visit. And we have hand hygiene and Purell or sanitation available as well. We do maintain social distancing in the office, so we're very conscious of that, and we have actually limited who is in the waiting rooms and how many patients are seen in the office at a time. And we do limit outside visitors during office visits and hospital stays, again, just to limit the number of bodies in and out of the hospital. And COVID-19 testing is performed prior to surgical procedures for all patients. And on that note, I want to thank you, and I'm open and excited to answer any questions that you may have.
Thank you very much, Dr. Min. Comprehensive, fascinating discussion, and that's why I think our Q&A is lighting up with questions. So let's take our first question from Anna. Is Myrbetriq an anticholinergic drug? And do you recommend this for OAB? How does it work and what are the side effects?
So that's a great question. Myrbetriq is the newest medication that we have available, and it was a very exciting medication when it first came out about 5-10 years ago. And it is not an anticholinergic. So it is a beta-3 agonist. It works to relax the bladder like an anticholinergic, but it works on different receptors. So, you know, many women don't have any side effects at all, which is great. So they don't have the dry mouth or constipation. But in a small subset of women, about 5% of women can be affected with an increase in blood pressure or the headaches that I had mentioned. So those are the most common side effects of that. I do strongly promote the use of Myrbetriq. Again, I think it's a great medication. Unfortunately, sometimes we are limited because of health insurance and what the insurance covers. So oftentimes insurance will want us to try an anticholinergic first because it's been around for so long and may be a little bit cheaper. And then we have to move on to the Myrbetriq after that.
Okay, so the next question comes from Daniela. I've heard reports that the mesh is not recommended by the FDA. Is that correct?
Yes, again, so that's a great question, and hopefully I addressed this, but it is the type of mesh that we don't use anymore, and that's through the vagina for the correction of prolapse is what we do not use anymore. And again, because that is just large sheets of mesh through very thin tissue that can cause those issues. But we do still use mesh for a slings, for a small piece of tape underneath the urethra, causes many less issues. And then also use mesh graft for the sacral colpopexy. Again, it has great success rates and really minimal side effects.
Okay, Dr. Amin, this question comes from Aileen. And again, I remind you all, they are anonymous, as these are people who have chosen to tell us their name. The question is, I have a vaginal prolapse where my bladder drops and presses against the front of the vagina. When I have the urge to urinate, I try to give it some time for the bladder to fully empty, but I feel I don't have control of when to know if it has emptied. If some urine remains, can this cause a urinary infection of the bladder?
Mm-hmm. So that can happen. And when the bladder does prolapse, that changes the angle of the urethra. It can cause a blockage so that the bladder cannot empty all the way. Because the bladder is trying to squeeze, but there's a blockage with where those pelvic floor muscles are located, and the urethra is almost kinked, so that it's not able to empty all the way. And you often do have that sensation. So sometimes when we don't empty, that is stagnant urine that's sitting there in the bladder, and that is a nidus for infections, for bladder infections. So that is sometimes the reason why we do prolapse repair, to fix that and unkink the urethra so that you're able to empty the bladder better.
Okay, this question is anonymous. What kind of biofeedback can assist as well as psychotherapy?
Oh, that's a great question. So biofeedback is something that you would often get when you were to go to, if you were to go to a pelvic floor physical therapist. And they give you clues and target different muscles and areas within the pelvis, and so that you're able to either relax those better and more efficiently, so that you're able to urinate better. And again, it's so important when you go to a session with a pelvic floor physical therapist that it's really, they'll give you more clues about knowing your pelvic floor and kind of thinking through the urination process a little bit better. But they do give you homework, and it's really important to continue to work on that at home as well. And psychotherapy, so I really like to think in terms of urinary incontinence in particular, and urinary symptoms, is the mind, body, and spirit. So there are so many other things that are involved with, again, between the brain and the communication between the brain and the bladder. So I also am a strong proponent of meditation and relaxation techniques as well, that can help and relax the pelvic floor muscles and relax the bladder, and then those nerves that communicate to the bladder as well, to relax and to decrease the urge.
Now, here's a question that is related to whether you do something or you do nothing. If you have bladder prolapse, will it continue prolapsing over the years if nothing is done?
That is another great question. So it can, or it could not, but often, it depends. Most patients are symptomatic once that prolapse reaches the vaginal opening. So prolapse can occur, and it hasn't even reached the vaginal opening. We just incidentally find it when we perform a pelvic exam. However, patients become symptomatic when the prolapse is at the vaginal opening. And over time, it can get worse. Again, our tissues can start to stretch out more. It's kind of like a bungee cord. It should be a bungee cord where it suspends and lifts things back up. But oftentimes the bungee cord can be overstretched, year after year, and it can get worse. But it's really just kind of a discussion. If you can, if you're proactive, physical therapy can be a great option as well. And it's really a discussion about how bothered you are, and discussion with your provider.
Another great question comes anonymously to us. Can cancer treatments, including radiation, dry out your body, and combined with vaginal prolapse from weight or childbirth, make intercourse very difficult?
Yes. So radiation in particular, what it does is it blocks the oxygenation or the blood vessels from forming, because again, the purpose is to really stop cancer. So it changes, everything kind of about that area that it's targeting. So it changes the blood flow and makes the tissue very stiff, and it's not as healthy anymore. So that can definitely cause urinary urgency and frequency, and particularly dryness, vaginal dryness. And when you add that on top of older age, after menopause, when we have less estrogen in our bodies, those can all kind of coincide together and cause that vaginal dryness.
I'm impressed by our participants who are paying close attention to every detail, because this question says, how long are the effects of a pessary for bladder prolapse to prevent further dropping? Does it fit like a diaphragm?
It does fit like a diaphragm. It's similar to that. But we really, the diaphragm is much thinner, and this is, again, a space occupying device. So it's really, what I say is the purpose is to create support, almost like, we're women, so it's almost like wearing a bra. That's what it should feel like, where you don't really necessarily feel it, but it's creating that support every day, but it's creating that support there. And it's not necessarily preventative for the prolapse. It's more to help improve your symptoms, so you don't feel that bulge or that heaviness. To really, again, the purpose is support. So it's not going to prevent the prolapse from changing, but it's really there to help support.
I know, Dr. Amin, you covered so many different treatments, but questions continue to come to us like, what is the best treatment or approach for vaginal prolapse, especially because of very painful intercourse?
That is a very tough question. So pain with intercourse can happen for so many different reasons. And I think that, performing a proper pelvic exam and talking to the patient about their symptoms, their individual symptoms, is so important. And like I said, there are many different ways to correct prolapse. And there's not one way that's better or the other. It's just what's best for you at that time.
And this question, I know, is going to be difficult for you to Monday morning quarterback because you don't see the patient, but here's a very specific detail. I urinate, but the bladder does not totally empty. A few minutes later, I have to go again. The doctor inserted a tube into my urethra and said there were no kinks. So what is wrong?
So that's a combination of the storage component and then also the urination component. So oftentimes you have the sensation where you have a strong urge to go to the bathroom after you just emptied, but your bladder could be empty, but you still have that sensation, and that's because the bladder muscle is squeezing when it should actually be, again, relaxed, and it should really only be squeezing in a controlled fashion when your brain is telling it to squeeze. But that's what's causing that urgency and frequency after urination. So that's sounds like more of a storage problem rather than a kinking of the urethra problem.
Okay. I remind everyone, all our participants who have been so proactive, that this lecture is going to be posted on the UMiami Health YouTube channel, but give us a week for the video to be added and in the queue so that you can listen to this, because it's a lot to take in, isn't it, Dr. Amin? And to see the variety of questions and the concerns and the amount of people who jumped on this talk, it really is on everyone's mind, on so many people's minds.
And I mean, I think that it's just important to seek the right, providers and that can offer help, and ask the right questions for you. And again, there's just so many different treatment options out there. So there's definitely ways that we can improve your symptoms and improve really your day-to-day life activities is really usually our goal for this.
Well, Dr. Amin, this has been, I think, very eye-opening for so many people. Let's see if we have one more question coming in here, because of course this could go for 2 hours, but I know we're limited tonight. Sometimes I feel like I need to empty my bladder, but leaking only occurs when standing or walking or when I cough or sneeze. And I know you said in one of your slides that that's one of the tests that you do, the coughing. How do you distinguish if it's the bladder or vaginal prolapse?
So it's a combination of the pelvic exam, again, taking those measurements, but it sounds like there's definitely a component of the weakening of the pelvic floor muscles. So that are supposed to, between that and the urinary sphincter, that should be closed when we're holding and storing urine, and to prevent leakage when we do cough or sneeze. So that's what we call stress urinary incontinence. So that component sounds like it's definitely there. Again, prolapse is really more having the symptoms of heaviness or bulge. So it sounds like that's more coinciding with stress urinary incontinence.
Well, I think that we've come to a conclusion. Dr. Katherine Amin, urologist, UMiami Health, an expert in the field that obviously affects so many people in this country and certainly in our community. So we want to thank you for a really wonderful discussion, and we've learned, there's more to learn, and I think it's important for the patients and the participants to do something about it, not just to knowledge is power, right? And for us to act. So thank you for being with us tonight. And we regret that we couldn't get to all of your excellent questions because they were impressive, but we thank you all for participating. Dr. Amin for giving us her valuable time. And we want you to know that we at UHealth appreciate your participation. We want to care for you. We do it on your terms. You want to come into the clinics, you know how to go about doing an appointment. You want to do it virtually. Telemedicine is part of your world right now. Visit umiamihealth.org so that you can learn your options and make an appointment. So we hope you enjoyed this talk tonight. We want you to complete the survey at the end of the talk and provide feedback on your experience and give us topics of interest to you as well. Okay, so stay safe, everyone, and have a great evening. Thank you, Dr. Amin.
Thank you. Thank you.